Welcome to Nurse Practitioners Changing Practice. I'm Carol.
Hi, I'm Nina.
And today we are just blessed to have Dr. Dan Young with us, who is a nephrologist in the area. He is with Midwest Nephrology, and I've worked with Dr. Young many years now. So you are just one of the best nephrologists, in my opinion, in the area. You take care of your patients so wonderfully. And we're really glad to have you with us tonight.
Yeah, this is great. Thank you for being with us.
Well, thank you for the kind introduction. I love podcasts and I love educating. I look for opportunities in private practice to educate my colleagues. I'm really excited to be here tonight.
So I know as a nurse practitioner, I have worked in the hospital. I've worked with you quite a bit there. And I've also worked out in rural America, where I've referred people to nephrologists, and I've been that primary caregiver. And I know that kidneys really play just a huge part in a lot of disease processes, the medicines we give, the issues with hypertension. I know that you are more the specialist with hypertension because kidneys have so much to do with that. Anemia, chronic disease, all of these things. And, like, when do we really need, what tests do we need to get? When do we really need to refer? So I know I've asked you a lot of things. You prepared some slides that we can go through. So I'm going to share my screen and I'm going to let you kind of walk us through this presentation. Let me go enable editing. Okay, and I'm going to put the slideshow from the beginning, and you can take it away.
Oh, great. Thanks, Carol. And thank you for giving me some ideas of high quality items to review tonight. I guess the first place I would start is whether you're taking care of a kidney patient or any patient. I would make sure that you pay attention to drug dosing, and I still use Hippocrates almost every day, a free drug reference that you can put on your Android or iPhone to look up drug dosing for different stages of kidney disease or different dosing for hemodialysis or peritoneal dialysis patients. Probably one of the most common drugs I see used maybe inappropriately, especially for CKD patients, is Bactrim double strength twice daily for 10 days. Bactrim is a great drug for the right patient, but for patients with an elevated creatinine or patients who are on medications that can increase the potassium, it's a very dangerous drug to use. And then also, I would draw attention to learning which drugs have long half-lives or which drug metabolites have long half-lives. For example, spironolactone itself as a drug has a short half-life, but its metabolites can last over 1 day. So sometimes I'll take care of patients in the hospital who have high potassiums, and it takes a couple days to resolve because the spironolactone metabolites are taking a while to get out of the system.
Glad you mentioned that too, because half-lives are huge. If you look at an elderly person, first of all, kidney function in an elderly person just decreases, even if they don't have chronic kidney disease to some degree, just aging. And like a drug like Haldol is grabbed very quickly, and it has a tremendous half-life. It's way out there.
Mm-hmm. And sometimes you can use that to your advantage. Amlodipine has a half-life of 52 hours. So if you need to give a medication 3 days a week, a blood pressure medication 3 days a week, that might be a great option. Chlorthalidone has a much longer half-life than hydrochlorothiazide. So that's another.
Why don't we see that used more often? I've heard that chlorthalidone has got a much better profile than hydrochlorothiazide, but we don't
use it. Yeah.
I think we should use it more often. And in fact, just a few weeks ago in the New England Journal of Medicine, there was an article looking at using chlorthalidone in essentially stage 4 CKD patients with GFRs of 15 to 30. And it was found to be an effective drug, lowering the blood pressure by, I think it was either 11 or 12 millimeters of mercury. So I think we should use it more often. And this recent paper.
Maybe we'll start seeing it then more often.
Yeah,
absolutely.
Yeah, I think you're right. I mean, like I said, I could count on my hands the time I've actually seen that as opposed to hydrochlorothiazide. Also, I learned early in my practice, and you can talk a little more about this, but like over 25 milligrams hydrochlorothiazide doesn't really do much more if you bump it to 50.
Yep.
Is that true?
For most of my patients, if I put them or have them on hydrochlorothiazide, I usually use 25. I do see 50 used from time to time.
Oh,
I think I would just worry more about the side effects,
Yeah.
hypokalemia and metabolic alkalosis with higher doses.
So this is the next slide for us.
Oh, so if you want to order the very most basic of labs for ongoing CKD care, and in my practice, I take care of a lot of different patient, SSM patients, BJC patients, Mercy, St. Luke's, VA, and I have some no-pay patients. So if I need just very basic tests for ongoing CKD care, these are the four I would recommend. A renal function panel, which is just a basic metabolic profile with an albumin and a phosphorus, a CBC to look at the hemoglobin, but sometimes the white cell count and the platelets can clue you into different disorders. A UA looking for hematuria, pyuria, or protein. And then also you want to do a random urine microalbumin to creatinine ratio, not only for your diabetics, but probably at least once a year for your hypertensives as well. And anyone who has CKD, you may want to do this at least once a year because sometimes you'll see non-diabetics, non-hypertensive with proteinuria, and that can be a clue to their underlying illness.
So I understand in the renal panel, the BMP and the albumin, what's the phosphorus going to tell us?
yeah.
So for your stage 3 patients, it's probably not going to add a whole lot to your care. If you see a low phosphorus, that typically is going to be inappropriate unless the patient is malnourished or not eating or something like that. You can start to see phosphorus elevations with stage 4 patients. And phosphorus really correlates with vascular calcification. So the majority of patients with CKD in the US and worldwide, the majority of them don't ever reach a point where they need dialysis. And we'd like to think it's because they're seeing great kidney doctors, but the truth is it's because they're going to struggle with heart disease or a stroke well before they reach that point. So anything you can do ahead of time to lower the risk of heart attack, stroke is really important. High phosphorus can be one clue that they're at a higher risk for vascular calcification, just as an elevated microalbumin to creatinine ratio can be.
So we see a high phosphorus, we want to be a little more aggressive on getting the lipids down.
Definitely, and making sure they're at blood pressure goal. And you may even want to have that patient get some phosphorus education from a dietitian. If they're close to needing dialysis, you may even put them on a phosphate binder.
Got it. All right, good information. Secondary hypertension. Now, I don't think this gets talked about enough. I see everybody just puts essential hypertension and they don't. I myself this year have discovered 3 cases of hyperaldosteronism that has been going on for a while.
And great work. Although I have chronic kidney disease at the top of my list here, really, I probably should put hyperaldosteronism at the top of the list. And to back up just a little bit, secondary hypertension, maybe 10 to 20% of the time, we can come up with a pretty good reason why an adult has high blood pressure. So that's really the patient we're referring to when we do a workup for secondary hypertension. There are over 200 genes in the body that help regulate blood pressure control. So, for the vast majority of adult patients, you're not going to be able to pinpoint their cause of high blood pressure to one thing. But this is the list I think about. And actually, when I see patients for secondary hypertension evaluations, I will print that list and I will bring that list into the office and review causes one by one with the patient. And CKD, that's going to be evident by blood tests. Hyperaldosteronism, you're going to have to check a renin level and an aldosterone level. Sleep apnea.
What's the cue for that? I mean, my cue has been that you'll get it wrong now, but the sodium and the potassium are off. And blood pressure.
So definitely those are things to look at. I think historically some of the other older docs will say if the sodium is a little bit high, that's one of their clues, and definitely aldosterone causes increased potassium secretion. So if they have a low potassium, but a lot of patients with normal potassiums can have hyperaldosteronism. I would say anybody who is not well controlled on one or two reasonable doses of blood pressure agents. I think checking a renin and an aldosterone level is really
So
good.
just be suspicious if you have somebody who you're having a hard time controlling.
I think so. Or somebody where it doesn't make sense. Really these secondary hypertensive patients are, somebody who has been stable for a long time and then all of a sudden their blood pressure is not well controlled, or somebody who's developing high blood pressure well before they should, the 35-year-old female.
So what about what I was going to say something with hyperaldosterone. Oh, well, go ahead. I'll think of it. I'm sorry. Go ahead and do the list.
For some of my patients, I'll go through the Ellsworth sleep scale to see if I need to refer them for a sleep study, rule out sleep apnea. If somebody has sleep apnea and you treat them with CPAP, it can result in, it's as good as another blood pressure medication on average, about a 7-point blood pressure reduction. Renal vascular disease, I think about this, and if somebody's had a CAT scan, I'll look for renal artery stenosis, but I rarely send patients for renal artery stenting. And fibromuscular dysplasia, you want to think about that in the young female with high blood pressure. Pheochromocytoma is very rare. I'm still looking for my first one. Same with Cushing's, but these disorders of the adrenal gland, you want to do 24-hour urines.
Yes.
Thyroid disorders, that's easily checked with starting with a TSH, and then hyperparathyroidism, your clue would be an inappropriately high calcium.
Yep. I tell my students always, you've got too much calcium, you check a PTH, that's your next test.
Yep.
Exactly. Obesity, we see a lot of patients with obesity, and I think that the important caveat there is I see a lot of patients where when they lose weight, I get to start removing some of their medications. Polycystic kidney disease, that's the most common genetic kidney disease. Those patients, you really want to have strict blood pressure control with them. And then medications, are they taking phenylephrine or pseudoephedrine? Sodium intake, sometimes I do 24-hour urine collections just to see what their sodium intake is. What goes in has to come out. And then alcohol, you want to do a good social history on these patients to see if they're drinking, how much they're drinking.
I remember my question now. In the hospital, we couldn't check a renin creatinine level. Am I right? It was a problem, but you can order that outpatient, right?
I think it may have been, we can order renin and aldosterone pretty easily in the hospitals. One of the hospitals did not allow us to check plasma metanephrines.
Okay. For pheochromocytoma. Okay.
Yep. And really you want to do 24-hour studies, but if they're only going to be in the hospital less than 24 hours, maybe you want to check the
So would you order a renin and aldosterone ratio, or do you order them? How do you order that?
How do you order
that? I would order them both. Sometimes they will be combined in a panel, and I try to order that so that there's no mix up in the lab where they get one result, not the other. And then if here's my rule of thumb. If the aldosterone level is less than 5, it's unlikely that they have a hyperaldosteronism. If it's over 15, it's pretty likely, and you might want to do adrenal imaging. If it's between 5 and 15, you want to put some thought into it, but they could have hyperaldosteronism.
That's a good tip.
That's a great tip.
It's a great tip.
Traditionally, I think that if the ratio is greater than 20, you thought about it, but I think if you maybe just focus on that 5 and 15 cutoff for aldosterone. That's a good rule of thumb.
Okay.
Now the natremias, hyper and hypo, those are confusing sometimes, is what to do for them.
In hypernatremia, we don't have to spend a lot of time on it, but I would say 95% of the time, it's just a water issue. So the nursing home patient who hasn't been eating for 4 days and gets admitted with a sodium of 156, you just need to pull out your free medical calculator, calculate their water deficit, and you can be pretty aggressive when you're replacing them with D5W. And a fast correction with hypernatremia is typically okay, unlike hyponatremia.
Oh, yeah, yeah.
Now, if you've done your correction and you've given them D5 and you come back the next day and the sodium hasn't budged, if their urine osmolality is low, that can be a clue that there's diabetes insipidus present, either central or nephrogenic.
And D5W is the fluid of choice here.
Well, probably just giving water by mouth would be the fluid of choice. But if they're obtunded, where it's not safe for them to drink, or if you don't have a DOB, HOF, or an NG, something that doesn't have additional sodium or chloride in it. So, but sometimes you can run into real high sugars with D5W. So
Yeah.
And anything for just like if they wanted to, they just put a water deficit calculator. Hippocrates should have that, right? They have calculators.
I think the two I use on my phone most often, one's called Calculate, and then the other one is called Neph Plus.
Neph Plus.
Yeah, but you could go to Google too and just do a Google search for, hypernatremia, calculate free water deficit.
Perfect. Okay, and then the biggie, hypo.
Hypo.
So
That's the messy one. Hydrochlorothiazide, big offender with that one too.
yeah, great segue into my second point. Like the medication review is critical. Are they on a thiazide or any distal diuretic?
Chlorthalidone might be even worse, right?
Yeah, chlorthalidone, you could have the same thing. Spironolactone.
Spironolactone.
Yeah, your loop diuretics are generally going to cause an increase in the sodium if they alter the sodium, whereas your thiazides and potassium sparing, if they have an effect on the sodium, it's usually to decrease it. If you can at least just start, once you recognize they have a low sodium, if you can start with a blood osmolality, a urine osmolality, and a urine sodium, you're going to be 95% ahead of most hospitalists in terms of managing hyponatremia.
So tell us what these are going to, what are we looking for? You will always tell me it's in the test. The test will tell you the cause. So can you explain a little more what you mean by that?
Yeah, so the blood osm, really, most of the time when you deal with hyponatremia, you're dealing with hypotonic hyponatremia. So you'd have a low blood osm, probably less than 275. Sometimes there are going to be other things in the blood, like proteins or cholesterol, especially if the cholesterol is real high, or if you have a multiple myeloma patient who has a really high M protein, you can get a high blood osm and a low sodium. Or if somebody has a high sugar, that's a real common cause of pseudohyponatremia in the hospital. If their blood sugar is 400 and their sodium is 129, the issue is their high blood sugar. But 95% of the time, probably the blood osm is going to be low, and you're going to confirm that they have hypotonic hyponatremia. So after that, you really want to do your medication review. You want to do your past medical history. You want to do your exam, and then the urine osm and the urine sodium are really going to clue you in. So
now your SSNRIs and your SSRIs are offenders too, right?
Yeah, anything that increases serotonin can increase ADH release and cause.
So anything. I mean, it could be tramadol.
Yeah, well, nausea can increase ADH release, pain can increase ADH release, narcotics can increase ADH release. Your anti-inflammatories, your non-steroidals can cause low sodium levels. When you have a low blood sodium level, you really should see a low urine sodium and a low urine osmolality. So if your urine sodium is not less than 20 or 30, and if your urine osm is not less than 100, that's when you have to start thinking about these alternative diagnoses. And then the last point I'll make about the hyponatremia is just you really want to work hard to avoid rapid correction, especially in small women and in patients with cirrhosis. You want to avoid the osmotic demyelination syndrome.
Okay. So in clinical, like if this was a patient I was seeing in clinical practice, they probably would, they might have chronically low, like their sodium might be in the 120s most of the time, and they don't have really any symptoms. Is that an indication that this is probably medication driven?
Not necessarily. I mean, one of the subsets of SIDH is reset osmostat. So there's a group of patients where their bodies just release ADH at different levels than the rest of us. But one thing I would tell you about that patient is they are at risk. So if you did, real specific neurologic testing, you could find abnormalities in those patients. They're going to be at risk for falls. Chronic hyponatremia increases their risk for osteoporosis. So you want to evaluate those patients and try to treat them. Most of my patients, I try to get them to 130 or higher.
Okay.
So as long as we're in our 130s, we're okay. But anybody, but it's getting below that, it's getting a little bit. What about our psychiatric patients? Have you run into what is that called? It's the
Psychogenic polydipsia. Yeah.
yeah, that where they drink water,
Yeah, and it causes their
all the
sodium to
time.
go down.
They get the sodium, and then they sometimes even have had seizures because they've drank so much water that it's really gone down dangerously low.
Yep. And your clue there is going to be they're going to have a low blood sodium. They're going to have a low blood osm, and their kidneys are doing the right thing. So you'll see a low urine sodium. You'll see a low urine osmolality, and most of the time you'll be fortunate to have a little bit of history that they're drinking
Yeah.
2 gallons of water a day.
2 gallons of water a day, right?
And those patients, they're easy to treat. You fluid restrict them, but these patients, you have to monitor them closely for rapid correction because their kidneys are working properly. So if you fluid restrict them quickly, their sodium can shoot
So
up.
what would be a safe fluid restriction?
It depends on the patient. I might start with 2 liters a day if they really have polydipsia, and just do sodium levels every 4 hours, every 6 hours in the hospital.
Okay, all right, that makes good sense. All right, well, anything else on hyponatremia?
Nope, just go slow.
Okay. Anemia of
Renal
disease.
Yeah, so some of the bullet points here, just in the dialysis units and in the clinic for stage 4, stage 5 CKD patients not on dialysis yet, we're going to target a hemoglobin of 10 to 11. And when we're correcting anemia, we're not keeping them alive longer. What we're hopefully doing is we're hopefully helping them to feel better, and we're also hopefully helping patients avoid blood transfusions. And that's important because you don't want someone to be sensitized needlessly, and that decreases their chance of getting a kidney transplant. And then also blood transfusions have their own risk profile side effects. So there are a couple different mechanisms for anemia in kidney disease. The kidneys produce erythropoietin. And so as kidney disease worsens, the kidneys might produce less, or if especially a hyperparathyroidism or high phosphorus levels, you might become resistant to the action of erythropoietin. I like to give the analogy of filling the gas tank before you step on the gas pedal. So I like to make sure that patients have enough iron before we start giving them Procrit or some other erythropoiesis stimulating
So
agent.
Venifer, is that there used to be one that I used to give that was 2 doses instead of the Venifer.
Oh, I think Injectafer can be given over 2 doses, but Venifer can be given over 3 doses, 3 days apart in the hospital.
So do you do 100 milligrams, or what dose do you like for Venifer?
So if I have someone and I really want to iron replete them in the hospital, I'll give them 300 milligrams daily over 3 days. If they're a heart failure patient and I know they're going to be there for a while, I'll do 200 milligrams daily over 5 days, because the 200 milligram can be given as a slow IV push in a small amount of volume over 10 minutes, whereas the 300 milligrams will come in a pretty good size bag.
What would you do outpatient?
Outpatient, I would give 300 milligrams weekly over 3 weeks.
Okay.
If I see that there are 2 cell lineages that are abnormal, I might refer those patients to hematology. So if I see that their white cell count is 2 and their hemoglobin is 9, I'm not going to necessarily work up their anemia and treat it myself. I might ask for hematology help. Or if they, same thing, if the platelet count is 57,000.
Yeah, that's a good point.
That's a really
important point.
And then I still use the MCV to help guide the evaluation. So if their MCV is 104, in addition to iron levels, I'll probably still check their B12 and folate levels.
What do you like that B12 level to be at? I mean, it's got a wide range. Sometimes they're like at 250, they're still above normal, but they're kind of on the low side.
Right, and I think, I don't know what the cutoff is, but less than 400, if you are really suspicious for B12 deficiency, you're supposed to check a methylmalonic acid level. I don't do that routinely. I'll typically just put them on a 90-day course of B12 and recheck their level after 3 months.
Okay.
But I still use the MCV to help guide my evaluation and management.
Yeah, I mean, that's the one I use definitely myself to see if it's macrocytic or microcytic.
Absolutely.
So Carol asked in the email, when should you refer to a nephrologist? And so I'll use this classification system to help answer that. And so we break patients up into different stages, and most of you are probably familiar with the stage 3, stage 4, and stage 5 CKD. Stage 3 patients have GFRs between 30 and 60, stage 4, 15 and 30. Stage 5 patients are less than 15, and then ESRD are patients on dialysis, typically a GFR less than 10. But what I'd like to point out here is I might be more worried about the patient who has a GFR of 65 with heavy protein in the urine than a patient with a GFR of 50 who has no protein in the urine.
Oh,
Okay, so the heavy protein in the urine tells me those patients are at much higher risk for needing dialysis in the future. They're also at a much higher risk for cardiovascular disease.
So I had a patient like this recently, just sent them to nephrology. So that's interesting. Okay.
And then those patients too, who have, a GFR, let's say between 30 and 90, but who have heavy protein in the urine, this is a really exciting time to treat these patients. We have new drugs like SGLT2 inhibitors and finerenone that can help to really have important outcome benefits if we start them at the right time.
Well, the Ozempic, the GLP-1s too are really cardiovascular protective as well. So
definitely. And going back to our first slide, you want to be careful with looking up any diabetes drug, the dosing in kidney failure. Metformin needs to be reduced with a GFR less than 45 and stopped with a GFR less than 30. In terms of sulfonylureas, glipizide is probably the safest for CKD patients. I'm really excited about
metformin. They've done some changing on the rules with that. It used to be we stopped it immediately if they had kidney disease, and now the GFR we're a little like it's less than 30, right?
Yep. Yeah. And I educate my patients it's not going to hurt their kidneys, but just there's a risk for a terrible acid condition like the acidosis that it's rare when it happens, but if it happens, it carries with it a 50% mortality rate. So we want to keep them safe. This new class of drugs, the SGLT2 inhibitors, I'm really excited about them. They in the proximal tubule, they block a sodium glucose transporter, so you start spilling extra sugar into the urine. And although they're mild to modest diabetes drugs, they have important effects on lowering the risk for cardiovascular events and the need for dialysis. So for a long time, we used ACE inhibitors and ARBs to lower proteinuria and help protect our diabetics. These SGLT2 inhibitors, it's a really exciting development for providers treating diabetics and heart failure.
Most diabetics would be on an SGLT2 now much quicker, right?
Much quicker. Yep.
Yeah, I think the big issue right now is still, most of my patients are Medicare patients on fixed budgets, and because these are new, they're all still
very
trade and can potentially be expensive. There are some contraindications to using these drugs in patients. So if they have critical limb ischemia or terrible PAD, you don't want to use them. Or if they're susceptible to genital mycotic infections, you don't want to use these drugs.
No, but they definitely have a lot of good promise.
Mm-hmm.
Plus, you get rid of all that glucose, you lose a little weight too.
A little weight loss is nice.
That's always a benefit. And then our wonderful Lasix. Now, Lasix we give when the kidney function gets a little worse, right? That we switch from hydrochlorothiazide or thiazide diuretics to more of a loop diuretic, right?
Well, so what I'll tell patients is, in general, hydrochlorothiazide, it's a really good blood pressure drug. It's kind of a weaker diuretic. Lasix, it's a decent blood pressure drug, but it's really good at helping get rid of extra fluid. And I like this slide. We all write for Lasix or other loop diuretics. The question comes up, is it better to give 20 milligrams twice a day or 40 milligrams once a day? And you wouldn't think there would be a difference, but there are going to be some patients who respond better to the BID dosing and some patients who respond better to the once daily dosing. It all depends what their dose response curves. So the patient on the left, and I'm sorry for the podcast listeners, they can't see the slide, but for the patient on the left, this patient is probably going to make a whole lot more urine with the 20 milligrams BID dosing. The patient on the right, they're not going to respond much at all to the 20 milligram dose, whether you give it twice a day or 3 times a day. So for that patient, the 40 milligram dose is going to be more effective. So what I would tell you is a diuretic, when you start it, you're going to see the maximum benefit within 2 weeks. So if I'm working with a patient to, in terms of its diuretic effect, so if I'm working with a patient to improve swelling in the outpatient setting, I will ask them to call in 2 to 3 weeks with a weight and a swelling update. In the hospital, if I don't see the results I want with my IV dosing, like I start doubling the dose every day.
So question that I have is sometimes I'll be in the hospital, acute CHF, right? And they bumped up their Lasix dose. Let's say normally was 40 milligrams BID and they discharge them on 80 milligrams BID.
Mhm.
Now they're in your office, you're the primary care doctor. Is this the new dose for them? Or do we need
Or do we
back
bump
off
it down?
at
Yeah.
some point? Are we over diuresing them? And how do we know that?
Well, I would start by looking at their labs. Is their sodium still normal? Is the potassium okay? Most diuretics can cause a little bit of an alkalosis. So is their bicarbonate okay? If their bicarbonate is 38, we may need to stop the Lasix for several days. And then, does their calcium look okay? And then on exam, like is their swelling better? Historically, does their weight look better? So I wouldn't be afraid to keep them on 80 milligrams twice a day if their labs looked okay, if their exam was favorable and their weight was improved. But even if their exam still showed fluid overload, if there was a problem with their labs, I might have to rethink my strategy.
And would you would check them a little more often for a little while to see how they're doing on that new dose, right?
Most likely, yeah.
Yeah, like maybe, I mean, I always had them come in every couple of weeks for a couple of weeks so I could, because in the hospital we can check their labs every day
Yeah.
and we can see how they're going. Well, when they're outpatient, we might not see them for, another month. And so much can happen. So when they first come home from the hospital on such a change, I like to watch them for a couple of weeks and then another couple of weeks to check things to see if it's stabilizing. Is that a good practice or doesn't really matter?
No, I think that's a great practice. If I saw an emergency on the labs, I'll probably direct them to the ER. If there's something I'm concerned about, maybe every week I would check labs on them to see.
Check them for a little while to see that we're at the right dose and nothing is getting too wonky from that, or if I need to adjust something. That's kind of been how I practiced. In the hospital, though, I'm spoiled because I can get them every day. All
Yeah, the
right.
key is to watch them close, especially when they come out of the hospital. That's really important.
Great point. This next slide, can a dialysis patient still make urine? Sometimes I hear in the hospital, oh, they're a dialysis patient, they don't make urine, and that may not be true. So even a patient with a GFR of 5, and remember GFR, although we'll typically refer to it in terms of percentage, it's really milliliters per minute per body surface area. So in this example, if a patient with a GFR of 5, they make urine 60 minutes a day, 24 hours a day, they might still filter 7.2 liters. So they may still generate 1 to 2 liters of urine. They can still make a normal amount of urine. And this is really important. Dialysis patients who can make more than 1 cup of urine per day actually have improved outcomes, hospitalization, mortality. So we try to protect dialysis patient's ability to still make urine. And actually, a lot of dialysis patients can benefit from high dose loop diuretics.
So when do you change from Lasix to, let's say, torsemide or, one of the other,
BMX.
yeah, Bumex?
If they've been on Lasix at a higher than expected dose or higher than typical dose for a couple of years, and we're not having success, that might be a good time to change. Torsemide and Bumex, they both have better bioavailability than Lasix. So when I give someone 40 milligrams of Lasix, they might absorb 30% of it. They might absorb 80% of it. I don't know. If I give someone 40 milligrams of torsemide, I know they're going to absorb almost 100% of it. And torsemide has a little bit longer half-life than Lasix.
So you're just going to get a little more for your bang for your buck, right?
Exactly.
All right. And then you've got some trivia for us.
Oh, this is great. So, and in the hospital, like, choosing the right fluid is really important. So sometimes, I'll get consulted after a few days and the sodium's high and the chloride's really high and the bicarbonate's low, and they've been getting normal saline for the past couple of days. So I like this slide because it just reminds you how much sodium is actually in 1 liter of normal saline. So 1 liter of normal saline has a little bit over 3,500 milligrams of sodium. And so that's equivalent to 20 small bags of potatoes.
Wow.
That's
a lot.
That's what we put everybody on, thinking it's not really going to do much of anything. It's just going to keep everything the same.
And I think we're getting smarter and more aware of our fluid resuscitation strategies in the hospital sometimes create problems later on.
Yeah.
So what would you recommend as the number one fluid to start somebody on? What do you like to see?
My practice pattern has changed. I use a lot more LR now than I did even 2 or 3 years ago.
Yeah, and even if somebody's slightly hyperkalemic, it's actually better, the LR. It doesn't do, they used to really shy away from that, and I've seen some articles that suggest LR.
I have too. Yeah.
Yeah, especially in the ER literature, because if they're acidotic, saline has a pH of 5.5. Right. Whereas LR has a little bit higher pH. So if you avoid worsening the acidosis, potentially the potassium can get better. And I also think the body doesn't have an infinite buffer source. At some point, you're going to start to see changes if you keep giving them normal saline. Now, if somebody has terrible liver disease, you can theoretically run into the same problem giving them liter after liter of LR, but I use a lot more LR now than I did 2 or 3 years ago.
Yeah, I think I'm beginning to see that trend a little bit more too from the ER, that they're coming up with LR instead of normal saline. And it used to always be normal saline. That was just what you saw, or you saw D5.5 normal.
D5.5.
Yep.
And that has its own issues too. So, but questions. Nina, I know you had a couple of great questions. One was about creatinine clearance. Right?
Yeah, talk a little about creatinine clearance and how what would you advise to use to calculate it, and how do you use it in practice?
I don't use creatinine clearance a lot. I know a lot of our older drug dosing was based on creatinine.
Yeah.
I'll tell you, probably once a quarter, I get a patient sent to me who has a slightly elevated creatinine, and I have to decide, does this patient really have CKD, or could this elevated creatinine be normal for this patient?
Okay.
So for that patient, I'll do a 24-hour, not only creatinine clearance, but also do a 24-hour urea clearance. So the creatinine clearance is gonna just overestimate the GFR. The urea clearance is gonna underestimate the GFR. So I'll take the average and kind of use that as a rough estimate of kidney function.
Okay.
In my dialysis patients who I think they might have recovered enough to come off dialysis, we'll do the same thing. We'll check a 24-hour urine creatinine clearance and a 24-hour urea clearance. We'll take the average, and if it's close to 20, we'll use that as a good gauge to maybe do a dialysis, a trial without dialysis.
Okay.
What about figuring out dosing for meds?
Yeah, dosing for meds. That's always a big question.
so I usually start with Hippocrates, but if
Yes.
I need more specific information, I'll go to something like Up to Date.
Up to date. Yeah, I use Up to Date a lot.
I use both of them. Now what are they using to figure, like they're using creatinine clearance.
Yeah.
I'm looking at Bactrim DS, okay? And I can give it renal dosing, creatinine clearance 10 to 30. So you would have to figure out what the creatinine clearance is to know
Right.
how to give them. And I use the calculator in Hippocrates to figure it out because it's not on the labs.
Nope.
Yeah, a lot of the EMRs will calculate it, but yeah, it doesn't get reported with the labs anymore. Most of the time, I'm going to substitute GFR for creatinine clearance.
Okay, so how do you do that?
Well, if their GFR is 30, I'll assume a creatinine clearance around 30. The other thing, if you want to cheat and you're in the hospital, you can call the pharmacy to ask them what they would do
love
for,
that.
drug dosing. The other thing is
you substitute GFR for, like if it says 10 to 30 for creatinine clearance, you make that GFR.
exactly.
Oh, okay.
Really?
So you could just say creatinine, the GFR is between 10 and 30. That's how you would dose it.
Right. Usually creatinine clearance is going to be a little bit higher than whatever the GFR is. So if the GFR
Okay,
is
so
20,
then you would save. Okay, gotcha. Okay.
Now I will caution you, in the hospital, we get labs every day. The computer calculates a GFR every day. Those are not reliable estimates.
Oh.
Okay. For example, if you get consulted and the patient has made no urine in the last 24 hours and the creatinine is 1.7 and the GFR estimate is 29, they don't have a GFR of 29. They don't have a creatinine clearance of 29. They have a GFR of 0.
Wow.
And same thing, if somebody one day has a creatinine of whatever and a GFR 40, and the next day the creatinine is higher and the GFR is 30, the GFR might even be lower than 30. Those estimates are not designed for the inpatient setting where numbers are changing day to day. They're used as decent estimates for the outpatient setting where the creatinine is stable over time. So sometimes you have to kind of think about the clinical scenario and maybe the GFRs is a guide, but use it as an overestimate to the true kidney function.
Very interesting.
What about fractional excretion of urine? Do you use that much? Do you find that to be very helpful?
I don't use fractional excretion of sodium or urea very much. I'll look at the urine sodium a lot, and if I really want to, I'll calculate the fractional excretion of sodium. But usually, the urine sodium by itself is gonna give you.
Oh, excellent.
The urine sodium will be unreliable if the patient is alkalotic. So if a patient has a bicarb, let's say above 30 or so, you might want to use the urine chloride instead of the urine sodium. But I don't calculate the FENA very often in my practice.
Okay. Wonderful.
Well, Dr. Young, I can't thank you enough. Any last words of wisdom that you can tell our students?
I would just say when you place consults, whether it's in the hospital or in the outpatient setting, and whether it's a nephrologist or some other consultant, I would recommend two things. Number one, have a question in mind. What is the question you want this consultant to answer? And the question could be as simple as, can you help me manage the low sodium in this patient? So that's a question, but have a question in mind when you're asking a consultant to assist with one of your patients. And then going along with that, you don't always have to consult us. So I would encourage you, one of the ways we all learn is by doing things on our own. If somebody has a mild case of AKI or a mild low sodium or a mild whatever, and you want to challenge yourself and learn how to manage it, contact your consultant. Say, hey, I'd like to curbside you. Here's what I'm dealing with. What would you recommend? And I think by getting that confidence that you can take care of this low sodium on your own, you're going to help a lot of patients down the road. And find a good consultant to work with, someone where you can bounce the same patient off them the next day or a couple days later, just in case things don't improve the direction you were hoping for. But I would say you don't always have to consult us. You can curbside us, and that'll be good for your confidence and for patient care.
That's excellent advice.
I can honestly attest that works. And I know you guys like texts, because you can text you and say, hey, I've got a patient, can I ask you a quick question? Then you can call us and we can talk about it. And you have been so helpful. You've even gotten in the computer and looked at things and said, oh yeah, maybe you want to try this. And if they're still not better, consult me, tomorrow or the next day. And that works in the outpatient world too. Because like you said, you don't want to be bombarded with every kidney patient ever, right? And we do learn by doing and trying different things and by talking to each other. Well, thank you.
Thank you, Dr. Young. This has been excellent.
I really enjoyed it. Thanks, ladies.
And for all of you listening, you can go to our YouTube channel, which is NPS Nurse Practitioners Changing Practice, which is NPS Changing Practice. You got to put the S on there. And it's on YouTube. It's on our podcast, which is npschangingpractice.com, or of course our podcast. Again, thank you for listening, and submit comments or suggestions on what other topics you would like us to present.